today the debate will be on crisis facilities should receive voluntary and involuntary referrals. And Dr. Margie Balfour will take the affirmative, and she is the Chief Quality and Clinical Innovations Chief of Quality and Clinical Innovations for Connections Health Solutions, and Travis Atkinson will be taking the negative, and Travis is the Director of Clinical and Crisis Services for TBD Solutions. And really excited that Dr. Chuck Browning, President and CEO of Behavioral Health Link, will be moderating this debate today. We're at episode 206 for the Crisis Jam. Next slide. And if this is the first time you have joined a Crisis Jam, and if you've joined many times, just a reminder that you can get past videos, past highlights, past materials at the Crisis Now website. And if you want to register for the Crisis Jam and you're watching this by YouTube, that's the website. And again, previous episodes are available to you. Great recordings, just really thrilled for that resource. Next slide. And the Crisis Jam has been so remarkable. There have been 500 unique speakers and over 200 episodes. So just super thrilled about that. And if you have an idea for a Crisis Jam topic, in the chat is a link to submit your idea. And look at all those people. Very, very cool. Also, just wanted to let you know about a tribute to Monica Johnson, who leads the 988 office at SAMHSA. There will be a kudos board if you want to do comments, gratitude, pictures to Monica. There's a link in the chat to be able to do that. Monica, thank you so much for all of your leadership and awesome work. You have just incredible cutting edge leadership. Thank you so much. And next slide. And wanted to highlight that Jessica Rosen-Worsel did her last FCC meeting. She is the chair of the FCC, and so this was a farewell meeting, her last meeting. And she was really talking about some of the biggest accomplishments from the Biden administration. And in particular, one of the pieces that was just so fantastic was the advance of public safety by improving the reliability of wireless emergency alerts and expanding support for the 988 Suicide and Crisis Lifeline, including geolocation capabilities for faster response times. So thank you so much. All right. And now we are at the Crisis Trivia Hot Seat. This one is going to be for all of us. And we're going to start with the question: the amount of involuntary referrals greatly varies. A study of 2014, in 2014 from 24 states found a rate of 357 emergency involuntary detentions per 100,000 people. However, the rate varied significantly between states. And of course, our debate is on some of this. So that's the relevance of the question. But which of the following is typically required for an involuntary referral and a behavioral health crisis? So A is individual's signed consent, a court order, law enforcement or doctor certification, that's B, or C, family member request, or D, voluntary agreement from the individual. So go ahead and put what you would put. The poll is up. Do it in the poll and not the chat. Let's take a look at what this answer might be. Not a trick question. Oh my gosh, we have a very knowledgeable audience here. 93%. I wish I wish all trivia hot seats were like this, had this kind of clarity. Court order, law enforcement, or doctor certification got 93% of our audience's answers. So let's take a look and see if 93% of our audience is correct. In most jurisdictions, an involuntary referral requires legal authority, such as a court order, law enforcement officer's decision, or a physician's certification based on evidence that the individual poses a risk to themselves or others. So it is B, court order, LEO, drop-off, or doctor certification. So good job. We have a great audience here. If you didn't know that, that's fine. I mean, we always want, you know, I can see how some of the other answers came up for you. So great. We all learn, right? Okay, next one. And we are now moving to our debate. I'm going to turn this over to Dr. Chuck Browning, who will be moderating. Go ahead, Dr. Browning. Thank you.
Thanks, Megan. So it seems like it was just a few months ago that I was sitting down with Margie and Travis and over a pizza after a nice conference and talking about things and having such a nice social event time. And here we are, we're going to have a fiery debate instead. I wanted to be able to do that deep voice of let's get ready to rumble. But I really love these debates and being able to hear from two such knowledgeable people taking two sides of a debate to kind of help us look at and inform this really important topic. So the debate is going to be structured around crisis facilities should take both voluntary and involuntary referrals. And we're going to start out with Dr. Margie Balfour, who has experience in her facilities in doing these. Before Margie gets started, we've got a pre-debate poll. So we'd love everybody to think through. So this is the to say definitively no, no, don't know, or not sure, yes, or definitively yes, about should crisis receiving centers or crisis facilities take both voluntary and involuntary. So we'll get this pre-poll, and then we'll have our debate structure and follow up with a post-debate polling of what the results are. So Margie, are you ready to take us off on the yes on why we should do this?
I'm ready.
Thanks.
Next slide. Next slide. Okay, so I want to start off by talking about what happens when you don't have crisis facilities that can serve involuntary individuals. So over on the left, you've got your first responders out there, police, mobile crisis, EMS, and they are dealing with high acuity individuals, the types of people who may need an involuntary commitment, people who are agitated, potentially violent, danger to themselves, danger to others. And, what are their options? Well, they've got jail, and we all know, I don't have to spend much time talking about why jail is bad to bring people for a behavioral health crisis. I think we all agree. The default is often the emergency room in most communities if you're going to bring people to treatment. But what happens in the ER is not great for people experiencing behavioral health crisis or behavioral health emergencies. There's less than half of emergency rooms actually have any psychiatric services available. It's about 46%, according to a poll of Medicare taking hospitals. So they're getting little to no treatment in a very stressful environment. They spend hours or days without treatment, boarding, waiting to be sent somewhere else, like an inpatient hospital where they can get some treatment. And then during that time, they may become agitated and assault staff, then they get arrested, which seems kind of unfair. Or they get restrained, oftentimes on a gurney in a hallway. And if you're a person of color, you're more likely to have these things happen to you. So, these are not, great outcomes for our people. Ideally, if you have a crisis center that can take these folks, there you have specialized treatment in a therapeutic milieu in a space that's specially designed for this population. You've got specialized staff, you've got psychiatrists, nurses, social workers, peers, and you can do this work with this population without using security guards. That's how we operate in our crisis centers. And most can actually be stabilized where you start treatment and you're engaging with them and their families and coordinating care. And either during that 23-hour observation period or if they stay a little bit longer, like in an extended like crisis stabilization unit, many can be discharged back out into the community without having to go to the hospital. And our research shows, we did a research study this past year, looking at our Tucson facility that showed that of our involuntary population, 60% we were able to engage with and to have them either get better or to the point where they didn't meet the criteria for involuntary commitment, or they were engaged and agreed to sign in voluntarily to continue their treatment. And then after the crisis, they were more likely to remain stable in the community and not have any more crisis utilization in the next 30 days than the voluntary population. I mean, we recently opened a center in Harrisburg, Pennsylvania, and our early data there shows that there's less involuntary commitments coming from the police, perhaps because when people have an option that's not an ER, maybe they're more willing to go. Um, and so the facilities that I'm talking about, if you've seen the new SAMHSA guidelines, I'm not talking about all crisis facilities. The guidelines separate them out into different levels of intensity. And so I'm talking about the ones on that high intensity end of the spectrum. In the SAMHSA parlance, they're called high intensity emergency behavioral health centers or hospital-based behavioral health emergency stabilization units, which are sort of also known as empath units. And so you need a crisis center that can take these folks. If you think about it from a systems perspective, it's kind of counterintuitive, but we all talk about wanting to do the least restrictive care for people. Well, if you don't have a crisis center, and I didn't have Lego crisis center example, so that's the best I could do there. But if you don't have a crisis center that can take these folks, they're going to default to these other levels of care. So what you've done is you've taken then your highest need people, your people who are the sickest, the people most in need of specialized care, and you've excluded them. Um, and so they've been deprived of the opportunity to have their crisis stabilized. They've been deprived of that opportunity to have staff that can engage with them and maybe convert them over to voluntary care. So from a systems perspective, you need a facility that can do involuntary crisis care, because when you sort of look overall, then that actually has less restrictive care for that population. And I think I did that in under 5 minutes, like I was supposed to.
You did, Margie. Thank you. Travis, are you free and ready to come on and go on the other side of why we should not have involuntary within crisis receiving centers?
I am ready, Chuck, and thank you so much
I'm
for
loving
having
the
me
bow
here.
tie, Travis.
Thank you. I appreciate that. So I am arguing that crisis facilities do not need to accept all referrals to be considered a crisis service. So recently, my brother gifted me a pair of shoes, and they were beautiful, they were stylish, but they didn't fit. And if I would have worn them, I would have been committing to a very uncomfortable experience. I'm sure many of you can relate to having a pair of shoes that don't fit, whether it was when you were young and growing older. But we often take for granted how good it feels when our shoes fit. But we're building our crisis services on a faulty assumption that they should be like blankets, something that is one size fits all, instead of something that is right-sized, something that helps a person right where they're at. So notions about all-encompassing, all-inclusive crisis care centers are rooted partly in the convenience of the individual and the families for ease of access, but they're more rooted in the convenience of law enforcement and treatment professionals to not have to carry nuance when referring someone to treatment. So you'll hear this often in models of good crisis care. They'll tout the number of law enforcement FTEs that are saved or the other efficiencies that are created, but that doesn't always speak to the appropriateness of treatment for that individual and whether, in fact, they needed to go through a locked door in order to receive the care that they did get. But in that 50-year quest to create alternatives to the status quo, that wasn't the intention of alternatives. If you think about mobile teams, 988 centers, crisis stabilization centers, crisis residential programs, they weren't meant to look like what they were replacing. They were designed to be decidedly different in function and approach with the promise of good or greater outcomes. So good crisis services today are also predicated on the idea that just like an artist relates to their self-portrait, a crisis is defined by the user. So respecting these parameters does the most to preserve agency and dignity and choice throughout a treatment experience. As Margie said, we have to think about keeping people in least restrictive environments. And the truth is, if you only have a crisis service in your community that is all inclusive and not one that can take voluntary individuals, then everybody looks like they're eligible to go to that one program. So if you or your loved ones were in crisis, when would you be okay with having freedoms and liberties taken away? Hopefully, it would only be when absolutely necessary. I want to show you a picture right here. Tell me, when you look at this living room, do you think that this could be considered a crisis facility? And if you don't, what are the reasons for that? Is it because it's not anti-ligature and people would have easy access to the outlets, or the furniture isn't bolted to the ground? Why wouldn't this meet your definition of a crisis service? Well, this is a picture from a peer respite program in Charlotte, North Carolina, run by Promise Resource Network. And peer respites and crisis residential programs across the country help to divert people from more intensive and more expensive levels of care. And that's another thing that we don't think about, is that when we send everybody through a service level that they don't need, it's expensive and it's restrictive, and it also impacts something that we call iatrogenic harm. And if you haven't heard of that phrase before, it's the concept that services and systems that are intended to help people can sometimes cause a substantial amount of harm to them. So we need these options. We need programs like the ones Margie's talking about, but we also need to consider that crisis residential programs and peer-run respites are also part of the crisis continuum. This past fall, I had a chance to visit a town in northeastern Italy called Trieste. Trieste is known the world over for their mental health care. As a matter of fact, the WHO has recognized them as one of the best places to receive mental health care in the world. And they have this building on their old state hospital campus, which has been closed and completely transformed into community services. And it says, the translation is, freedom is therapeutic. Now in Trieste, they take a very intentional approach with their housing, with their employment, and with their inclusion in community. Only 30% of their community mental health clients have to take medications. They have 4 inpatient beds for a population of 200,000 people, and they're rarely full. So the way that we approach these issues is important, and that we shouldn't assume that just because we have the ability to create a locked facility that we should send people through that.
Travis, Jana said you clearly did debate in high school. That's a great analogy about the shoes. So can we bring both of us, all 3 of us here together, to kind of talk through some follow through and questions? Margie,
Yeah.
there you go, Margie. So you both had great points on either side of this lane. Currently in the United States, we do still have a significant use of involuntary commitments across the spectrum. And Margie identified a need that if the crisis facilities are geared to do care quicker in a more customer friendly way than some of our classic symptoms that we've had. And so that there is a benefit in where those people are going to go if you don't have it. But Travis really brought up the point of that we should, for any of us, if we were designing a system for our own needs or loved one needs, you wouldn't want to be in a traumatic feeling situation. You want to have as much control as possible. I would argue, even if you're on involuntary commitment, you want as much choice within that as possible. So a question to both of you, and just to get your thoughts on it, is two lanes. One is, within the system, how do you get the best of both? Considering we still have involuntary commitments, and that's a thing, and we have folks who sometimes are at such a level that there is concerns about being in a facility like the picture that you showed, Travis, is beautiful. And how do you do that within a community? What are your thoughts about that? And then the second piece is, for a facility that does both, how do you minimize trauma, minimize iatrogenic harm, and overlap and connect and do good care with both as best as possible? Because those are tough lines. So thoughts?
Yeah, I mean, from a systems perspective, I always ask like when I hear people talking about, oh, our community is going to build a new crisis center, I'm like, oh, great, like tell me about it. And then if I start to hear, well, it's only going to be for voluntary people, I'm like, well, okay, great. Where are the involuntary people going to go? And if the answer is, well, they're still going to have to go to the emergency room and wait for a state hospital bed, I'm like, well, that's great for that crisis that you have, but for your community, that's not good enough. Your sickest people are, not going to benefit from these new services. So I agree with Travis that there are, overkill is maybe not the best word, but it's the best one I can think of right now. But for people who don't need that high intensity level of care, it probably is overkill to have them in one of these high intensity centers, for all the reasons that Travis said. I kind of, I like analogies. I like to make slides. I have another one I've been playing around with where it's got like the OG Super Mario from Donkey Kong, where he was made out of like just, like 8 pixels and big and blocky, and you can barely tell that's Mario. And then you've got Nintendo 64 Mario that has like a bajillion pixels. You want a higher resolution crisis center or crisis system where you have the different levels of care for the right population. Um, but I think communities need to, so then it becomes a choice of, well, do we want to start with something that we can build right now that's low intensity, or do we want to focus on our sickest people first? That's a decision for communities to make. But within the facility, to sort of the second half of your question, we do, we at Connections really specialize in this high acuity population. That's kind of our thing, and we do it without security guards. And when we talk to people around in other parts of the country, or other communities, a lot of people think if you're going to treat this population, you have to have security there, and like that's not true. We'd rather invest our money in people in our staff that are clinical staff, peers, and our behavioral health techs who get tons and tons of training. So why would we default to someone who has less training, like a security guard, to manage these folks? And so it's that kind of thinking that makes the experience better for these high acuity people, where for the longest time, the conventional wisdom is, well, they need to go to an ER and be restrained on a gurney in a hallway.
Good points. Travis?
Chuck, I want to give credit to my esteemed colleague here, Margie, for the efforts that she's done in developing metrics for crisis services. I think it's really important when you have facilities that accept all individuals or facilities that don't, that you're monitoring things like rate of seclusion and restraint, how often you have to do some kind of intervention. And those numbers should be expected to be very low. And everybody should be committed to the outcomes of those numbers. But we should be mindful that this is a classic psychology concept that people act in the way that you expect them or prepare for them to act. Think about the Stanford prison experiments, where people were assigned to be prisoners or to be, people who are locked up. They found the roles, they took it, and it escalated very quickly. And when we send a message to people from where we send them that they need these certain things for their own safety or for their own good, we're preparing possibly to have people have a higher likelihood of an incident. We see this also in the design of psychiatric hospitals in the United States versus in Europe. In Europe, they take a very permissive approach, and they say, we believe that people that the best is going to come out of people even when they're struggling. And if you look at how often we design facilities to be, very safety focused and not very choice or freedom focused, that can affect your psyche. That can also lead to some iatrogenic harm in that process too. So I believe that our system needs places like Margie talked about where involuntary individuals need to go, but we have to monitor how often we're doing that and look in other parts of the country or other parts of the world that say, why are people are people inherently sicker in our communities that we need to have a higher rate or incidence? If so, what is the reason for that? And what good do we have to gain from having more peer respites and more unlocked alternatives to psychiatric hospitalization? We have to remember that psychiatric hospitals, for however long they've been around, or crisis stabilization centers, the admission criteria is a construct. It's the best idea we have right now that has been built up over years or decades. But that we turn the idea of meeting criteria for that facility on its head when we are able to prove that individuals with some of those presenting symptoms can handle or function, thrive in a less restrictive environment.
Yeah, your both your points are still resonating on that. In an ideal scenario, we have a place for everyone to go, no matter what level of challenges that they're dealing with in their crisis, and that it's warm and welcoming and engaging and uses best practices. But the challenge is within a facility being able to carry that out and execute it. And then within a community to be able to have those different levels. And in an ideal scenario, no one would ever have to be on an involuntary commitment, and people would be safe. And you're so right, Travis, and that how you treat people has an impact on how that's going to happen. And what a great debate to be able to talk about the yes or no. Any other final closing comments? Travis, I tell you what, you did take away one of my questions, which I was going to ask you both. What are the best ways that we could grow in getting better at measuring that when we are doing involuntary commitment within a crisis center that we're doing it well and minimizing iatrogenic harm and maximizing engagement and connection and caring so that people can have best chances of having a good experience, decreasing the safety things that were going on that led to the involuntary commitment and move on. On the other hand, you ask the question, how can we measure when sites are voluntary only, what that does to the community and what's missing or not missing to that group of people who might not be able to be safely managed there. Any thoughts or comments? We've got this is probably like a less than 1 minute answer for each of you.
Yeah,
I'm happy.
Oh, go ahead.
I'll let you close, Margie, if that's okay. Chuck, I think what we're trying to answer in all of our industry is how can we be the most helpful? And if we take a very safety-minded approach to the most acute individuals and say, how can we be the most helpful? That is having a place for them to go that is going to address their mental health or substance use needs, that preferably isn't jail or isn't some type of incarceration setting, and gets them the help that they need. Now, being the most helpful to people who are voluntary, that's a different question to answer. That's maybe more about a therapeutic milieu and an environment. My biggest concern is people have historically looked at these 3 steps that SAMHSA published about 5 years ago, is that they would think that there is simplicity in this and that you only need one service type for each. Let's remember that some of the most well-researched services in the crisis continuum are home-like, unlocked alternatives to psychiatric hospitalization. So when communities are making choices about how to build out their crisis continuum, I think they're going to fall short and they're going to overserve or over-restrict people if they don't have options that serve certain populations as well as options that serve all populations.
Margie?
And oftentimes you hear these things couched, when we're doing a debate, right? It's point counterpoint as opposites, but recovery model versus medical model, things like that. And I've always seen it as a more of a pyramid, where when you're talking about this high acuity group, you've got the base of your triangle, like Maslow's hierarchy, right? Is keeping people safe, hospital level safety standards for this population. And then you layer on top of that the recovery oriented services, the engagement, the peers, the environmental design to try to make it as nice and calming as possible so that you're actually doing both. And I really am glad that SAMHSA, if someone mentioned cost and how much does this cost in the chat, and it is expensive to do what I described. It's less expensive than a week in the hospital, but it's more expensive than a lower acuity center. And for the longest time, we just had the words crisis stabilization unit to encompass all of that. And one of the reasons why SAMHSA, and all of us, all 3 of us here, were on that work group, to start to actually define these different levels, because that lays the groundwork for being able to do system planning where everyone's speaking the same language about, well, what types of facilities for what types of person. And importantly, then, well, okay, how are we going to reimburse these? Because this one costs more than this one. This one's a different population than this one. And so those SAMHSA guidelines really were meant to be like the first step in getting to that, where we have parity and we have different levels of care like you have on the medical kind of community-based care side.
Yeah, thank you both so much for such a rich discussion. and lots of good points and counterpoints to it. So we'll pass it back to Megan for our roundtable.
That was incredible, and it didn't even go the way I thought it was going to go. I learned so much from that. Let's bring up our roundtable. Dr. Scott Zeller, Vice President of Acute Psychiatry at Virtuity, as well as Elon Javanfard, who is Senior Director of Whole Person Care at D.D. Hirsch, and Chris Thompson, who is Chief Operating Officer at Lenape Valley Foundation. So Dr. Zeller, if we could start with you, please, and just what are some comments, reactions, and your perspective on the debate?
Well, I agree with you. I think it was a really great debate. And, I think really important that everybody resonated with the idea that there's different levels of care. And we saw that with the new SAMHSA guidelines that we do need, places for people to go when they are at that higher acuity. In a perfect day, hopefully someday, as Chuck was mentioning, we won't ever need to have people on involuntary status, but we're unfortunately not there yet. I think the one thing that often is left out of discussions is that, involuntary care doesn't have to be unpleasant. It doesn't have to seem like sending somebody to prison. We can have very home-like environments like what Travis was showing for involuntary care. We're seeing that with Marcy's Crisis Center, or we see that with empath units, that you can still have that kind of comfortable home-like living room atmosphere for a very high acuity and involuntary population, and people can do quite well with that. Sometimes people only think of high acuity involuntary patients as the agitated, intoxicated person, but remember that there's also sometimes people who are very withdrawn and highly suicidal and maybe making a suicide attempt, but refusing care. And they just leave me alone so I can kill myself. And they're much more withdrawn and kind of the opposite of the agitated patient. Yet those are folks who are still involuntary as well. And yet we see both those types of folks doing well in a more therapeutic environment for involuntary patients. And I think at the end of the day, when we're talking about no wrong door, if you're going to have that as part of your crisis system, you have to have some place where if somebody comes in involuntarily, they're not turned away, because then that's a wrong door, right? Everybody needs to have some kind of treatment, and if you do have higher acuity folks who are involuntary, they shouldn't be consigned to the ER or to some kind of other jail-like situation, because we're abandoning them, and they deserve treatment just like everybody else.
Dr. Zeller, thank you so much. Bringing those two concepts together, I think, is really helpful. We're starting to look at the elephant and understand the bigger picture. And let's go to, is it Elon or Ellen?
Yes, Elon.
Okay, wonderful. Yeah, please give us your perspective. Would love it.
I pronounce my name typically by saying it's like Musk, but without the money. I concur with what Dr. Zeller was saying, and I concur with what we've been hearing a lot. And I think to take a step back from this starting point, which is we should have ethical places for people who are voluntary to be able to receive dignity and care in a home-like environment. We should have ethical places for people who are involuntary to also have a home-like environment as well and experience that type of care. The question is, should they both be in the same place? I don't think any of us are disagreeing that the involuntary environments of hospitalizations right now are ones that are a challenge. But when we use this concept of no wrong door, we make it sound like these are the only options and choices we have. And I think taking a step back and thinking through the lens of when you describe a facility that accepts involuntary individuals and voluntary individuals, what I'm hearing is we're trying to create an ethical IMD. Wonderful. That would be great to have an ethical IMD. There are hospitals, there is hospitalization, and we should be emphasizing creating home-like environments there and ethical considerations there, not necessarily taking away from the voluntary system of care where there are people who are gaining their recovery in a different environment in a different fashion. And I think the thing that comes to mind for me is like a summarizing quote for myself is that mixing voluntary and involuntary individuals into crisis facilities really compromises the therapeutic environment because it does increase the safety risks for everyone. It shifts the focus from recovery to containment, which might be undermining the programs. Because by doing that, you create an environment that can disrupt the dynamic of care for the individuals who are there. You increase the burden on the staff. And in some ways, for the people who are voluntary, it still feels like they're in detention with individuals who are currently experiencing voluntary care. And I think that is the consideration of separating the two. Not that both people don't deserve dignity, care, and a good home-like environment. The question really comes down to, should they be in the same facility at the same time?
That another piece, right? That's why we have all these perspectives. Thank you so much for bringing that that perspective. And let's go to Chris Thompson, please.
Hi,
Chris,
everybody.
go
Thank
ahead.
you. That was an excellent debate. And thank you, Alon and Dr. Zeller. I think what I'd like to do is kind of piggyback on Alon's question about should these levels of care be provided in the same program, kind of building on this concept of no wrong door. I'm going to argue that, yes, they should be. And my point for that, my argument for that is, as we have somebody coming into a facility, let's say they're on an involuntary commitment, the goal should be to stabilize that individual as quickly as possible and provide them with a degree of relief, right? And I would argue that's ethical. That is providing a good deal of empathy for the individual. And if you have lower levels of care available within the same program, then you can step that individual down quickly. And you don't have to, organize some kind of transport to another level of care. You can do it within that program. Now, I recognize that this could increase the cost of building these kinds of facilities. But nevertheless, the ability to stabilize an individual and step them down to a lower level of care within, let's say, 24 hours within the same program really does hit home on this idea of no wrong door. I do agree that individuals who are voluntary and involuntary should most likely be separated to reduce the risk of injury or things of that nature if somebody's really escalated and struggling. But again, providing that individual with empathetic care, ethical care, so that we can help them de-escalate and come to a more emotionally regulated state, so they can be treated in a lower level of care that's more freeing in a home-like environment, of course. One thing that real quick, that I did want to hit on that was not really talked much about, but also the ability to address an individual's substance use needs, I think needs to be considered in a no wrong door environment. Again, many folks who come in on an involuntary commitment might be struggling with substance use, experiencing withdrawal symptoms, and need an intervention to manage that appropriately. So that's also something that should be considered in this. But again, I agree with the broader concepts that we're discussing here, that we need ethical care that really injects a bunch of hope in the recovery of somebody who's struggling with a mental health crisis. This concept of unconditional positive regard for the individual needs to be the guiding principle. So, thank you.
Thank you so much, Chris. God, what a fascinating conversation. Thank you very, very much. Now, this is a post survey. So you did the pre-survey, and now we want to see if there was any change in your perspective from listening to the debate as well as the roundtable. So crisis facilities should take both voluntary and involuntary referral, and choose one. Definitely no, no, don't know, not sure, yes, definitely yes. And so go ahead and submit your answer. And I will tell you that a more in-depth analysis will be provided next week. So that means join next week and find out why people maybe change their perspective or where things moved, check it out. All right. Okay. So we don't have results. Okay. So the next debates, and we are trying to do more debates. The next one is February 26th. And it is on all states should enact legislation that includes a 988 fee, similar to how we pay for 911. And that's with Hannah Wasilowski as well as Tom Betlak. And then the next debate after that, it's coming April 2nd with Justin Chase and Preston Looper on mobile crisis should always be dispatched by the local 988. A lot of people are talking about that. So that's very interesting. Next. And coming April 30th would be Jennifer Mathis and Dr. Brian Hepburn, that an IMD should apply to beds in an emergency behavioral health / crisis receiving facility. Great. So looking forward to those debates. They are really hot topics. A lot of people talk about these things if you go to a conference and they're talking about them on the side at any kind of coffee. So this is going to be very exciting. So thank you. Important dialogue, as Stephanie Hepburn just noted. And now we're going to go to Carrie Slatton Hodges. Welcome, Carrie. Super excited. Carrie is the new Executive Director, CEO, Chief Executive of the Nashville Research Institute. Carrie, just super excited. Go ahead.
Thank you. I know so many of you on here from the different work that we've been involved in, whether that's been from my role in Oklahoma as the commissioner there, or what was my home team of Nashville. And I'm thrilled to be with the Nashville Research Institute now as the executive director. And I want to tell you a little bit about NRI and what we do. I've put our website there in the link. If you go to our website, you will see lots and lots of great reports that come out of NRI, many of them to do with crisis care. You'll see different state profile reports, such as the funding of community mental health centers that we published in December, or support for 24-hour crisis receiving and stabilization facilities, which we published in November. Behavioral health crisis technology and outcomes, which we also did in December. So there are many types of things around crisis that you will find on there to give you information and perspectives about what is going on across the nation in crisis care. In addition to that, we do state peer-to-peer learning exchange calls on crisis topics. So for example, January 8th, we did calls around medical clearance for crisis services. And then in March 27th, we'll have private insurance paying for crisis services. We'll have a call on that from a state peer-to-peer learning exchange. So please check out our website where you can find all of that information. In addition, we're continuing to gather data across the nation on crisis care and crisis services, and you'll be seeing new reports coming out as we continue to move along. But I also wanted to tell you a little bit about some of the things NRI does that you may not be as familiar with. One is that we work with hospital systems across the nation to help them with their data and their analytics, in particular for reporting for CMS and those types of requirements. So we can help states gather that information, package that information, analyze how they're doing relative to other national measures around that, and look at things such as social drivers of health measurement sets, global population measures, the screening for metabolic disorders, etc. So we do a lot of work around that and helping hospitals look at their data, submit their data, analyze their data. And then also we're able to do personalized analytics and support for hospitals from a PQI perspective, so that they can understand who they're serving, what the issues are around what they're serving, how does that look compared to the rest of the nation, what kind of assessments they're using, what kind of clinical tools would be helpful. So we do all kinds of work around that. And then in addition, we also do mock surveys and a review of documents for Joint Commission and CMS. And so I put my email address in the chat in case you're interested in any of those things. One last thing, in addition, we do bespoke research and analysis on many different things. We've done that for provider systems, state systems. If you have something that you're doing that you want to really get data and research behind to show others how well it's working, or to compare how you're doing against other states or other systems, we are happy to do that work for you as well. So I just here today to say hello to everybody from my new role, and please reach out if you have any thoughts or questions or are interested in anything that I talked about today. So thank you so much. Back to you, Megan.
Terry, thank you so much, and congratulations on your new role. Your leadership is absolutely incredible, and so just very excited that you're doing this. So,
thank you, Megan.
Absolutely. And let's move to Sarah Corcoran, who is with Guide Consulting, to give us some federal updates. Go ahead, Sarah.
Thank you, Megan. So I've got 3 quick updates coming from Capitol Hill. The first update is yesterday, the Senate Finance Committee advanced the nomination for RFK Jr. for HHS Secretary to the full Senate. We expect a vote of the full Senate sometime likely next week, given that they just advanced that nomination out of committee yesterday. The second update is on FY25 appropriations, which we are in the midst of FY25. So just want to flag that the current continuing resolution deadline is March 14th. So we've got a little over a month until our current funding deadline runs out. Appropriators in the House and Senate, both parties are in the midst of negotiations to try to find agreement on top line funding numbers for the rest of this current fiscal year. So we are closely monitoring that as things develop, but just wanted to flag that current continuing resolution is up in a little over a month at this point. The third update is a bill reintroduction that actually happened yesterday in the House. Reps Obernolte from California and Dingle from Michigan reintroduced the cybersecurity bill on 988. That did pass the House last Congress, but it did not pass the Senate, so they reintroduced it yesterday. So I will drop a link to the bill press release that went out yesterday, and we'll, of course, monitor as that bill is considered in the House and if there is a counterpart in the Senate. Those are my 3 updates for the day, and I will drop the link in the chat. Thank you so much, Megan.
Thank you, Sarah, and all the work that you do. You're absolutely amazing. So, and let's go to Zach Immel. Dr. Immel, I really hope I'm pronouncing your name right. Is it Immel?
Yes, yeah, you got it.
Oh, excellent. Okay, you're with the Data Corner, and you're going to share your slides. Go for it.
Yes, and I'm sending a request so I can do that. Don't have sharing privileges just yet. Let's see. Sorry, everyone. There we go. Okay. So I wanted to share just a little quick research update from some stuff I've been thinking about that I think is relevant to this group that's really interesting. So this is a paper from a group of folks that I know at Stanford, Georgia Tech, and IBM. And here's the basic context. Some of you might be seeing cars like this now, right? Where you're driving along and there's this little heads-up display and you can get all sorts of updates, and it's kind of cool. But there's plenty of research suggests it might be cool, but it also might not be very helpful at times. It actually might be quite distracting. And there's similar questions starting to appear in the context of counseling, where yes, there's lots of variability in quality and outcomes in counseling. It would be nice if we could support counselors during the conversation rather than after. But what are the trade-offs we have to think about if we're going to start intervening in the moment in what has traditionally been just two people talking, right? And so here, this is a paper that comes from Dee Yang's group at Stanford, really, really awesome computer scientist who is heavily interested in mental health and is doing lots and lots of interesting stuff. Here's a link to the paper. In brief, what they did was they took a peer counseling program that they were working with. They used simulated conversation. So this is a study not using folks who were seeking help, but the clients were the researchers. Then they developed some really neat machine learning guidance where the platform itself both predicted the likelihood that a different type of counseling strategy would be helpful, and then generated an example helpful response that the counselor could then select from. They recruited around 15 counselors, and then they asked them to try this software out in a role play scenario. So this is kind of what it looks like. And if you want to look into the paper that I gave a link to, there's some really neat machine learning in here. But basically, it makes a statistical guess on which type of intervention, usually from an MI perspective, might be helpful. And then it uses some of this generative AI technology that you've heard of to suggest a possible response. And then the counselor can choose to use that, or they can choose to edit it or ignore it. And so here's an example of what that looks like. You're having this ongoing conversation. The counselor's in blue here asking questions, giving feedback. And then when it comes up for them, they see a category of different types of interventions they might make. They can select that conversation and add it. So this is an example from the study. They picked one of the statements, but then they added something on that they thought was missing. So this is an example of what the tech looks like. They evaluated that in 30 different conversations that included around 470 different counselor statements. What I think is most interesting is that about half of the counselors found it helpful. A bunch of them really didn't find it helpful, but also about half used the responses that were suggested, and that 60% of those were sent unedited. So exactly what the system said, they went ahead and sent. But here's what I think's just as interesting, which is, yes, there was lots of interesting things that they found and liked about it, but about half of people found it was disruptive in their thinking. It interfered with what they were trying to do, and it limited the response space of what they might say, because it sort of foreclosed what they might say otherwise. And so I think it's just this is really new work. There's not a lot of work out here like this, but the technology is starting to come online where it can't. But the research necessary to make this helpful is going to have to be at the intersection of machine learning, mental health care, cognitive science, user-centered design, to really think about, yeah, there's neat technology, but is it really going to help anybody? And how do we use it? And here's one more follow-up paper if you want to dig deeper. Instead of making suggestions, they make edits suggestions. So the counselor writes something in the platform, but the machine learning suggests, oh, well, what if you said it like that? It's another interesting paper out there. That's all I got. Thanks.
Wow, that is cool. What a great information, Dr. Emmel. Thank you very, very much. And we're just gonna bring back up the slides. Always learn so much from the Crisis Jam. And we are now going to move to Crisis Talk with Stephanie Hepburn. And Stephanie, are you on?
I
know
am.
You're on. I saw your comments in the box. Yeah,
Yeah.
you're there, right?
Yep.
There you are. Okay, great. Go ahead.
Thank you. So I'd like to welcome my colleague, Paul Galdiz. He's the Deputy CEO at Recovery Innovations, and he was also the external partner to SAMHSA, one of the external partners to SAMHSA's updated National Behavioral Health Crisis Care Guidelines. Paul, can you share some of the differences between the old and new iterations of the guidelines that participants should know about?
Sure, Stephanie. I think it was covered really well in the debate, and I think it might have been Travis that talked about this a little bit. And he started reflecting on the 2020 iteration of the SAMHSA National Guidelines. The title itself is the National Guidelines for Behavioral Health Crisis Care Best Practice Toolkit. It really leaned into the emergency behavioral health response, or language of no wrong door. How do you get a resource out there when somebody needs help, when they need care, that they can connect to care that feels like care? And it focused solely on that. And so if you think about an analogy in the physical health world, it would be a document that describes 911 EMS response in the community in a hospital emergency department. It didn't describe all the things for individuals with physical health challenges that would really benefit. And I think what happened in this new iteration, and of course, speaking just my thoughts here, is that the title reflects what it is. It's SAMHSA's National Guidelines for Behavioral Health Coordinated System of Crisis Care. And so they're going through and saying, look, you need a whole system. You want to align and give services that would actually reflect the least intrusive service for someone, the less restrictive environment, the one that makes sense to the person. And so it goes through a much larger continuum. And I think one of the things it also does nicely is it describes it with terms of emergency response, crisis response, and crisis-related services in the document. And then lastly, since it is a coordinated system of crisis care, I think of it as realizing something Sam Cochran discussed many decades ago when he came through with CIT, which is this community collaboration and partnership. And if you think of what SAMHSA did here, they start describing not only the collaboration between behavioral health providers, law enforcement, individuals with lived experience, advocates, and payers, but they say, if you're designing a system, everyone should be at the table. You should start figuring out what this looks like. You figure out what works for everybody. And I think that's really important. So those that spend time in this document, it's talking about an approach for designing your services. It's talking about collaboration. And it says, consider including all of the things we heard in the debate there, in the emergency response, the crisis response, and crisis-related services, so you get the service that makes sense for each person.
So whole person care as well. So housing and other resources too, and supports. It also includes model definitions, right? And I wanted to just we probably have 1 minute left, maybe less. If you could just touch on what you'd like to see next with the model definitions, what would you like to see in the future?
Yeah, I think it's a start. I think Margie leaned into this, or Scott Zeller did, that we were looking for something that's going to get all payers paid. We're going to hold them accountable for parity. And I think we have a few steps left to get there. We need to structure coding in a way that's going to do that. We have to get service definitions that really tightly define this is exactly what it is. And I think this was a big step in the right direction. I think there's probably a little bit more work to do so that we can actually across the nation say, look, crisis care gets paid by all payers. This shouldn't be covered solely by local taxpayers, which is unfortunately what happens for most communities now.
Thank you so much for joining me, Paul. I'll send it back to you, Megan.
Thanks, Stephanie.
Thank you.
Thank you both. Really great information and just so grateful. So it looks like we've got those debates that we talked about earlier, February 26th, April 2nd, and April 30th. And as you can see from these debates, they bring a lot of depth. And so we are just really excited about these opportunities. They're fun, they're respectful, substantive. And so we appreciate the debaters today, Dr. Balfour, as well as Travis, and the roundtable. So thank you so much for watching, everybody, and hope that you can apply it in your lives. And notice that there were tons and tons of comments. So I do want to, I think that's indicative of how important the information was that was shared. Thank you, everybody. Take care.